Welcome and thanks for joining us, Dr. Levy.
And thank you for having me. I'm excited to be here today to be able to share some of our work and also to give a little bit more insight and depth into the preterm myocardium and how the preterm myocardium responds to different perturbations and insults. So the learning objectives is threefold. We will discuss the determinants of cardiovascular mechanics in neonates, so give kind of a basic overview. We're going to try and understand what makes the preterm myocardium unique. And then I'll finish off by evaluating how novel hemodynamic applications of cardiac mechanics can inform neonatal diseases. And as was mentioned at the top, please put your questions in the chat, and I'll try and answer them at the end. So why do I care about the preterm myocardium? Well, what we've learned over time from this figure, specifically from Karagos and Steve Abman, is with cardiovascular endowment on the y-axis, that there's an inherent normal cardiovascular development and aging. But with an insult, a primary insult such as prematurity or an insult to the placenta, genetic, epigenetic environment, there could be disruptive cardiovascular development, which leads to a decrease in the cardiovascular endowment and will increase the susceptibility to secondary insults. So with a further secondary insult, for example, hemodynamic, hypoxia, infection, toxins, or even diet, the clinical phenotype will emerge with cardiovascular outcomes. So it's really fascinating when you take a step back and you try and understand the neonatal myocardial mechanics. You understand it from kind of 6 unique domains, from embryology to morphology, at the cellular level, performance, metabolism, and vascular tone. If you're caring for a preterm baby, you're probably doing all of this already, but it behooves us all to understand the fundamentals. So from an embryological standpoint, I like to think about it from the evolution of the cardiovascular system. This is a little bit of history. So it was the ancient Greeks and Hippocrates that were the first ones to really describe the relationship of the heart to the rest of the body. Fascinating, it was believed that blood actually originated in the liver, traveled to the heart, and the heart only sent blood to the lungs for nourishment, and then the lungs returned air to the left side of the heart, and it was the air that supplied all of the nutrients to the body. We know that's not exactly how it works, but then Galen came along, and Galen said, well, for blood to go from the right side of the heart to the left side of the heart, there had to be invisible pores that existed. And this way of thinking actually existed for almost 1,500 years through what we call the Dark Age. Anybody who challenged this thinking was actually considered to be a heretic and put to death. And we know that William Harvey, who's considered the father of cardiovascular physiology, said that it was a closed system where blood came to the right side of the heart, went to the lungs, came back to the left side of the heart. And that is how we have nourishment to all of the different systems in the body. Bring us to 2021. We know that cardiovascular embryology is really built on a platform that's linked to both airway development, which all of us are very familiar with, from the embryonic stage to the alveolar stage. And the vascular development arises from a temporal and spatially controlled process that's linked to cardiac growth that actually precedes airway development and airway development. There are unique genetic and embryologic key regulators that assist from gestational age week 2 to week 7 that helps with the folding of the heart and the formation of the chambers and the great vessels. So any perturbations to these kind of key regulators can lead to either congenital heart disease or an abnormal response with postnatal insults. When we talk about morphology, most of us understand the layers of the heart, the location of the heart, the chamber structure, and the fiber orientation. What's unique is that the right side is not the same as the left side. And a neonatal and a preterm heart is not the same as an adult heart. What we know from cardiac growth is that at 25 weeks, the heart weighs about 4 grams. Really the weight of a nickel here, you see. And up to 40 weeks, it weighs around 20 grams. In today's day and age, the weight of an N95. The adult female heart, all jokes aside, weigh about 250 grams. The adult male heart weighs 290 grams. The term heart weighs 20 grams, and the preterm heart weighs anywhere from 4 to 15 grams. Now, I'm a big fan, big soccer fan. That's about half the weight of a soccer ball for the female heart. For the male heart, it's the weight of a proper job. The term heart's the weight of a Duracell battery, and the premature heart, for anybody who is visiting us from England, is the weight of the English coin, the pound. So when I talk about cardiovascular fibers, it's important to understand how the fibers wrap around the heart. So in the superficial layer, you have a superficial layer of fibers that wraps around both the right and the left ventricle. Immediately beneath that, wrapping around the back of the heart, is another superficial oblique layer that wraps around both the right and the left side of the heart. There are shared kind of deeper longitudinal fibers between the right and the left. And finally, the left side has its own unique circumferential fibers that give us the twisting or the torsion of the heart. So in summary, for anyone who's seen this for the first time, the right ventricle has 2 unique sets of fibers, and the left ventricle has 3 unique sets of fibers. So as we develop new tools to assess cardiac performance, we need to take into account the unique fiber orientation that each tool is trying to assess, where the right ventricle only has 2 and the left ventricle has 3. Next, we can look at the cellular level of the heart. And this is important to understand for some of the features that I'll highlight when we get to the metabolism and performance. But at the cellular level, these come from some old electron microscopies of preclinical studies. You can see in the preterm heart, there's just one mitochondria, and the myofibril is towards the periphery. In the term heart, the myofibrils are very well organized. There's multiple mitochondria. So already at the cellular level, the preterm heart is just not as well organized. We can see this extremely nicely in this caricature. We can see in the preterm heart, there's a very disorganized sarcoplasmic reticulum. The nuclei are large. But in the term heart, you can see very well organized T tubules, which link the sarcolemma to the sarcoplasmic reticulum. You have a small nuclei and a much more organized sarcoplasmic reticulum. So how does that really translate clinically? Well, a lot of us have learned calcium metabolism back in medical school. And what we know is that the term infant relies heavily on these L-type channels. The L-type channels brings calcium into the cell, which activates release of a large amount of intracellular calcium, which then promotes contraction and relaxation. And overall, this process is facilitated by the transverse tubules and the L-type channels. Well, in the preterm heart, guess what? There's less L-type channels. There are underdeveloped T tubules. So the preterm heart cannot rely on the same calcium metabolism process, where calcium helps with muscle contraction, cardiac development, development of the conductive system, and all of our housekeeping functions. So if you have an immature sarcoplasmic reticulum, you'll have an immature calcium response. How does this translate clinically? Well, all of us are becoming much more familiar with the use of milrinone, which is a selective phosphodiesterase 3 inhibitor. In the cardiac muscle cell, we know that it can promote contractility and increase stroke volume with the blockage of phosphodiesterase 3. Now, in the smooth muscle cell, we know that it can promote vasodilation by dropping our SVR, our afterload, and increasing pulmonary vasodilation. But in the preterm infant who has an immature sarcoplasmic reticulum, it's very unclear, and it's an individual response of how milrinone will respond. Furthermore, term infants that are being cooled, they also will have an immature sarcoplasmic reticulum. It's all based on the calcium metabolism. So we have to be very careful in how we select different medications because of the impact that it'll have on the premature heart. So next, we talk about the metabolism or metabolic and the filler up, as I call it. So in the preterm infant, they rely heavily on glucose and lactate. They have a decreased ability of oxygen consumption, but they are able to tolerate hypoxia much better than the term infant or the adult. How does this translate clinically? All of us have been in that delivery room. All of us have seen the term and the preterm baby who've had a pH of 7.1, but for some reason they're able to tolerate this. This has been further highlighted by work by Shahab Nouri as early as 2013, where he looked at measures of function in figure A on the y-axis and measures of contractility in figure B on the y-axis, and showed that irrespective of the pH, all the way ranging from 7 to 7.5, the function and the contractility was relatively preserved. If we move on to myocardial mechanics, this is really the crux of how we develop novel non-invasive imaging modalities and measures. So when I think of the components of the cardiovascular system, I think of the cardiovascular system in terms of three domains. I think of the heart, I think of the vasculature, and I think of the blood. The heart acts as a pump, the vasculature acts as a transport network, and the blood acts as a transport vehicle. It's all a balance between oxygen consumption and oxygen delivery. And what we've learned over the last 15 years, it's really a balance of cellular metabolism, or as Patrick McNamara likes to say, cellular homeostasis, where it is an interplay between cardiac output, blood delivery and consumption, and the target organ. And what we know is that the cardiac output is more than just stroke volume and heart rate. What we know is that it is a balance of the preload, the afterload, and contractility. Clinically speaking, all of us have cared for that baby with hypotension or low blood pressure. Is the low blood pressure because afterload is reduced? Is the low blood pressure because there's less preload? Or is the low blood pressure because of contractility? If you just throw fluid at the baby, if you just put the baby on an inotropic medication, but you don't understand the root cause of the hypotension, you will be dead on arrival. So these are the important features that determine the function of the cardiac output. For those who are interested in HIE and neurovascular development, we think of the target organ as the brain, and we think of cardiac output with its target organ and cerebral autoregulation. For those who are fascinated by pulmonary hypertension and pulmonary vascular disease, we think of the target organ as the lungs, where the right ventricular performance is the piece of the puzzle that will give us insight to cellular metabolism. But what's unique about the preterm heart is that the preload, afterload, and contractility are all diminished in some function or another. So if you look at contractility, what we've learned in figure A is that the collagen to total protein ratio on the y-axis is extremely high early in gestation, and it decreases over the years, where 80% of the preterm myocardium is non-contractile. We've learned in figures B and C that compared between term and preterm lambs, there's severe fibrosis, likely due to an inflammatory process or immune process in the preterm lamb, which really lends us to understand that there's a decreased contractile state of preterm myocardium. When we look at the relationship between afterload and contractility, so how much blood can leave the heart, what's the resistance? So what we know from these figures in figure A and figure B, we understand with contractility on the y-axis and afterload on the x-axis that neonates have a steeper slope, a higher basal contractile state, and they are poorly tolerant to changes in afterload. So as afterload goes up, the contractility will not be able to match the demand. Similarly, with the Frank-Starling relationship, where you have stroke volume or cardiac output on the y-axis in figure A and B, and you have preload or LV end diastolic volume on the x-axis in figure A and B, as you have more blood in that left atrium per se, as the preload goes up, the fibers will stretch. That will augment stroke volume and cardiac output, but the immature heart will meet its limit. It will not be able to augment the stroke volume to the same extent as a mature heart. As we see in figure B, with the 7-day-old lambs that function as the preterm example, you won't be able to get high cardiac output with increasing preload, will lend to increased diastolic dysfunction. And finally, we look at the neuroendocrine or the vascular system. We've learned over time that the parasympathetic system is actually fully developed shortly after birth, but it's the sympathetic innervation that's incomplete. You have an underdeveloped autonomic system, which leads to decreased adrenergic innervation and reduced net inotropic effects of agents. So back to the example with milrinone and other inotropic or cardiotropic medications. You can keep titrating up those meds in the preterm heart, but there comes a point where the preterm heart just won't respond to it because the sympathetic innervation is just incomplete. So when you put it all together in this first part of the talk, it's important to understand that you have a cellular process that changes over time from the embryonic stage all the way to the adult stage. You have metabolism and oxygen capacity that will increase over time. And finally, how the preterm heart and the term heart and the adult heart responds to changes in loading conditions alters. But what's very interesting is you look at that preterm heart, and it actually mirrors what we would find in an adult disease state. But we know that not all preterm hearts are diseased. However, we have to handle this with extreme care as we are trying to target and manage these children one by one. So I want to shift now to understanding the hemodynamic assessment of cardiac mechanics, now that we have a good understanding of how the preterm heart is different. So in neonates, you can look at cardiac MRI, cardiac CT, cardiac catheterization, but those are not the easiest modalities to get in a sick preterm infant. Echocardiography is essentially the gold standard for the initial diagnostic workup for almost any disease that relates to the cardiovascular system. There is a wish list, a gold standard, where we would like to have a measure or a set of measures that fits a gold standard, that is accurate along an entire gestational age or birth weight, that provides continuous measurements, that's reliable, practical, feasible, safe, offers early diagnosis, and can be used in both congenital heart disease and structurally normal hearts. So the issue is that there's no one measure that fits all 7 of these criteria that William DeBoot outlined back in 2010. What we do know is that the assessment of cardiac mechanics with echocardiography can fall into 3 unique categories. This is an echocardiogram from Afifo Kufash, my friend in Ireland, where he's looking at 3 methods of cardiac function. We have a change in cavity from the largest in diastole to the smallest in systole. Examples are ejection fraction on the left and fractional area of change on the right. You also can look at the second method, which is a displacement and velocity of a single point from baseline during end diastole to a new point at end systole. Examples are tissue Doppler imaging, TAPSE, MAPSE. All of these measures give us a sense of the displacement. And finally, some novel measures that are more sensitive and more specific are deformation, which is a change in the shape in diastole from baseline to a new deformed shape in systole. So this is the new strain imaging or myocardial work. So basically, if you try and understand the measures, we should go back to the determinants of cardiac function. So this is an example of RV performance. So if you're looking at measures of preload, afterload, and contractility, and morphology, you can look at specific measures that can be obtained by echocardiography. We recently published an article focused specifically on pulmonary hypertension, which outlined several of these measures, looking at systolic function, diastolic function, looking at measures of RV afterload beyond the TR jet, beyond septal wall hypertrophy, beyond the septum, looking at linear dimensions, and of course, thinking about shunts, the left heart, and systemic circulation. Just as an example, whenever we try and take a measure from the adult world and we bring it into pediatrics or neonatology, it has to follow a strict 3-prong approach. We need to determine if it's feasible or reproducible. Does it compare to a gold standard? What are the mechanistic approach or the phenotyping? What are the maturational changes? What are the reference patterns? And then only then, if we achieve step 1 and step 2, can we use these measures to assess the efficacy of patient management strategies. Can these measures be considered outcomes? Do they make a clinical difference? Do we react to changes in management? So for each one of these measures, my good friend Afif Kufash and I, we have worked with countless of junior faculty and fellows and senior faculty to really validate each one of the measures of RV afterload, RV performance, and LV performance in both neonates and preterm neonates, both asymptomatic and in different disease states. Much of this has been summarized over the last 7 to 8 years. A really good reference is an article written by Colm Briatnik and Afif, looking at these novel methods to assess cardiac function.
Unmuted.
So, just as an example, strain imaging. I just wanted to walk you through this and show you how we kind of brought this from the bench to the bedside over the last 12 years. So it's a deformation of a segment of myocardial tissue. It basically gives us insight into how the heart contracts and relaxes. It's been shown to be more sensitive and specific than the traditional measures of ejection fraction. So back in 2013, we determined that it was feasible and reproducible. We looked a little deeper, looking at some of the impact on heart rate and frame rate. More recently, we compared different vendors in children and neonates, all while showing that it's feasible and reproducible along the spectrum from the preterm infant up to the child. Next, we discovered normal ranges of right ventricular function. We looked at normal ranges of left ventricular function with these strain or deformation patterns. And finally, we looked at them in the preterm population, all giving us a sense of reference patterns. So this fulfills step 1 and step 2. What we needed to do was understand how these measures would play out in health and disease. In other words, with observational studies, how would these track over time, and then could we use these measures as outcome markers? So to begin our odyssey and our journey, I had the fortunate opportunity to work with the Premature and Respiratory Outcomes Program, or the PROP. It was a multi-center study sponsored by the NIH. We recruited over 800 babies, where the objectives of the PROP were to identify biomarkers and develop non-invasive clinical variables in extreme preterm infants that were either associated with or predictive of pulmonary status in the preterm infant up to 1 year of age. The PROP study design was fascinating. It recruited babies in the first week of age. It obtained detailed phenotyping, DNA, urine, tracheal aspirates, daily respiratory, nutritional, medication, and stool. It followed the babies into the outpatient world at up to 1 year of age. And finally, at WashU in St. Louis, where I had the fortunate opportunity to train and work in my early years, we did hemodynamic assessment with echocardiograms at multiple time points over the first year of age. And what we were able to show with our assessment, and this comes from one of our fellows, Colin Erickson, who's now completing medical school, is that with the evaluation of that measure of strain, looking at right ventricular function over the first year of age, we showed that in comparison to term infants, highlighted in green, that all preterm infants had reduced right ventricular function as early as 32 weeks, that persisted into 1 year of age, and was more pronounced, highlighted in blue, in children who had lung disease, BPD, or pulmonary vascular disease, chronic pulmonary hypertension. What was more fascinating is that at 1 year of age, all preterm infants, so the preterm infants with no lung disease, no heart disease, highlighted in orange, and the preterm infants with lung disease or heart disease, highlighted in blue, had higher pulmonary vascular resistance compared to all term infants at 1 year of age, irrespective of how they were clinically doing. This really provided us some insight that preterm infants, even out to 1 year of age and potentially beyond, are not normal. So we decided that we needed to now apply these measures with outcomes. So the outcome measures were going to be the cardiac performance and pulmonary hemodynamics. Our exposure in this group was going to be consumption of mother's own milk. As I mentioned, we acquired detailed nutritional phenotyping over that first 30 up to 36 weeks post-menstrual age and discharge. And the subjects were the preterm infants. So we recruited 137 infants at birth, followed 117 to 32 weeks, 36 weeks, and 80 preterm infants returned at 1 year of age. We compared our nutritional and cardiac data with 100 healthy infants at 1 month and 1 year of age. What we showed actually was a little unexpected, but what we found was that with figure A, where we have RV function on the y-axis, and figure B, LV function on the y-axis, the more weeks that a preterm infant was exposed to the mother's own milk, the better the function was at 1 year of age, both on the right side and the left side. This persisted both for cardiac morphology, both right and left side as well. Interestingly enough, we determined using some nice statistical analyses that exposure to 28 days of mother's own milk in the neonatal period had good right ventricular function and LV function with high sensitivity and specificity. Now, these normal values were based on our previous work for the meta-analysis that I had previously shown. So if a baby gets 28 days of mother's own milk, they will have enhanced cardiac function at 1 year of age. For the right side, this actually starts to show up as early as 36 weeks. Interestingly enough, when we compare this to the term population and broke the cohorts into high and low breast milk exposure based on the 28-day mark, we found that babies who received higher amounts of breast milk, highlighted in orange, both for right ventricular function in figure A and left ventricular function in figure B, they had enhanced cardiac function at 1 year of age that approached those of almost near term. So it's almost as if it is normalizing the extreme cardiac phenotypes of prematurity. Now, the question I always get is, how does this play out with donor breast milk? We did sub-analysis and found that the donor breast milk was evident to have a positive effect on right ventricular function only really towards 1 year of age. We just weren't powered to answer it completely. And then the mechanisms of why this occurs is still unknown. We wrote a position paper, kind of an editorial thinking about it. Could it be VEGF? Could it be stem cells? Could it be HMOs? I think more data is needed to understand this kind of observational findings. And finally, what we really wanted to understand was, how does the unique preterm myocardium and the impact that is occurring over the first year of age, so where you have altered LV and RV performance, you have changes in morphology, you have persistent pulmonary vascular disease, how does this play into what we've learned about the adult cardiovascular phenotype? We know that adults who are born preterm are at risk for hypertension with arterial stiffness. They have decreased exercise tolerance. They have increased hypoxia intolerance. They have abnormal RV and LV function. And all of this plays into consequences where you could have early onset heart failure, ischemic heart disease, pulmonary hypertension, and systemic hypertension. But what connected everything? So we did a meta-analysis trying to compare measures that we had validated over the last 10 or 15 years of RV and LV performance between term and preterm subjects. Using meta-analysis statistical approach, we ended up identifying 38 studies, 20 in the neonates, 12 in the infants, 7 in children and adults, that directly compared healthy term and healthy preterm infants using these measures outlined on the screen. And what we found, this is just one example, this is a forest plot. We found that along the way, all of the measures favored those in the term infants. So what we found was that preterm infants have decreased RV and LV systolic function, decreased RV and LV diastolic function, and smaller and thicker right and left ventricles all the way from infancy through adulthood, with some exceptions along the way. But for the most part, we have definitely shown that there is a unique link between the preterm myocardium, the cardiac window of development over the first year of age, and what occurs in childhood and early adulthood. So the preterm birth and cardiovascular outcomes have been really well described, where they all will increase the mortality and morbidity of these adults who are born preterm. And what we can see here in the last kind of 10 minutes, what I want to show is how do these hemodynamic applications of cardiac mechanics inform our neonatal diseases? When I think of phenotypes, I think of disease types. I think of all of the diseases that could affect both the preterm and term infant, ranging from vein of Galen, HIE, trisomy 21, all the way down to the more common preterm-related extreme prematurity, chronic lung disease, pulmonary hypertension, and the ductus. So let me walk you through what I mean by the ductus. So when I'm thinking about the PDA, it's a hot topic in neonatology. It's been a hot topic for many years. It's become more hot with the introduction of the Piccolo device, transcatheter closure. But when we think about the hemodynamics of the PDA, we know that when you have a left to right, a systemic to pulmonary shunt through the PDA, you are shunting blood into the lungs, causing pulmonary overcirculation, leading to systemic hypoperfusion, and that could be a no-no. It can lead to long-term complications. So if you have a duct that you consider to be hemodynamically significant, and you want to close it, and you fail conservative management or medical management, and you want to go for definitive closure of the PDA, either with a clip or a device, what you essentially have done is all the blood that was going into the lungs is now going out to the body. And all the blood that was supposed to go to the lungs, it doesn't go to the lungs, and it doesn't come to the left atrium, so there is a decrease or normalization in the preload. So you have less blood coming to the left atrium, and all the blood that's going out to the body that was supposed to go to the lungs, the body says, I don't want all that blood, and will increase its afterload. So you have a state where you have a decrease in preload, an increase in afterload. And what I showed you at the beginning of the talk is that the preterm myocardium can sometimes not handle the changes in the preload from Frank-Starling and the changes in the afterload. Not all babies will have a negative impact following definitive closure of the PDA, but the question is, this post-ligation cardiac syndrome, as there is less blood leaving the heart and less blood coming into the heart, and a decrease in the contractility and the contractile functions, what you end up getting is a state where you have systemic hypoperfusion, and you'll have a backup of blood into the lungs where you could have ventilatory failure and oxygenation failure. This entity was first recognized 10 or 15 years ago by some of the fathers of the field, Shahab Nouri, Patrick McNamara, and it's pretty predictable onset of 6 to 12 hours. So the question is now, with the introduction of the Piccolo device, do we still see the same impact as we do with definitive ligation? We know that there are risk factors. We know if you're smaller, you're younger, you have hemodynamic instability prior, if you are more likely to not have a contractile response to increasing afterload and decreasing preload, all of that can lead to worsening post-closure or post-ligation cardiac syndrome. So the group at Nationwide, led by Carl Bax, first showed us that yes, post-ligation syndrome can exist in babies who have their PDAs closed with a device. Showed here, more pronounced in babies less than 3 kilos. The group in Iowa, looking at their first 30 cases, also showed that there was kind of a composite outcome, almost of 50% of their kids who had some evidence of post-ligation syndrome. They used those advanced metrics with targeted neonatal echo. They also used novel approaches with respiratory severity scoring, looking at FiO2 and the mean airway pressure. Now, our own experience in Boston focused more on the respiratory phenotype. And what we were able to show is that those babies who underwent ligation had higher respiratory severity scores immediately following the procedure, up to 12 hours, that were predictive of who would escalate from conventional ventilation onto high frequency ventilation. As more babies undergo this procedure, we will continue to learn more about the post-closure syndrome, but want everybody to understand that it is still a true entity that exists when you have definitive closure of the PDA in a certain subpopulation of the preterm infants with the known risk factors. And finally, the last example I wanted to give was trisomy 21. So Down syndrome has long been a mystery to anybody who's cared for these babies. What we've learned over the last 5 or 6 years is that a baby born with Down syndrome is at risk to develop cardiac dysfunction and pulmonary hypertension. Up until 4 years ago, the reported incidence of pulmonary hypertension in non-congenital heart disease and Down syndrome was less than 5%. With these advanced metrics, we've been able to identify that the incidence actually could be as high as 28 to 34%. This was confirmed with work out in Ireland led by fetal, in work in Colorado led by Steve Abed and Douglas Bush. So basically, in a nice prospective study by the Irish group, where they tracked 60 term infants with no heart disease, 60 Down syndrome babies with heart disease, and 60 Down syndrome babies without heart disease, what they showed with those advanced metrics of LV and RV function in figures A and B is that over the first 2 years of age, irrespective of your clinical exam, term infants had greater RV and LV function, these controls, compared to the Downs, irrespective of the degree of congenital heart disease. So there could be an intrinsic insult on these babies with Down syndrome that could be further revealed with these advanced cardiac metrics. So the take-home message for me, when I'm thinking about neonatology, hemodynamics, and cardiovascular outcomes, is that the cardiovascular development is a highly coordinated process that is linked through programmed structural, functional, and genetic mechanisms in that preterm and even the term infants. The preterm cardiovascular system is underdeveloped and has underdeveloped responses to changing and loading conditions. What I mean by that is the preload, the afterload, the contractility, and the altered morphology. As we choose specific medications, we need to understand the milieu of the preterm cardiovascular system. And finally, enhanced hemodynamic monitoring tools should be used for combination with the clinical exam. They don't replace the clinical exam. They help us use the clinical exam to serve as a catalyst both for clinical and prospectively physiology-based research. And with that, I'd like to acknowledge all of my collaborators. And again, thank you all for the invitation to be able to speak today. And I'm happy to answer any questions. Thank you. Just looking at the meeting, the chat to see if there are any questions. But feel free to ask me the questions as well.
Thank you, Dr. Levy, for that wonderful overview. I think a topic that we don't always explore much in our specialty of neonatology, and I'm glad that you've brought some light to it. I think one of the questions that I have after hearing all of this is, what is some of the best ways for us to understand the dynamics of the preterm heart in terms of vasoactive medications that might be used frequently, the changing landscape of a lot of units transitioning from dopamine to other vasoactives like epinephrine and norepinephrine for babies that have either hypotension or other signs of low cardiac output, and the role of echo in that, whether it's through having our cardiac colleagues come by and do it or through neonatology-based echoes.
Yeah, that's a wonderful question. I think it's really engaging the hemodynamics and the physiology. As we go over the next 1 to 3 to 5 to 10 years, you will see more hemodynamic programs pop up that will mirror what's going on in Iowa and in Canada and in Australia, where they're able to use echocardiography in real time to assist the hemodynamic evaluation. For the programs that don't yet have access to echocardiography 24/7 or don't have the access to the full-time echocardiograms, it's also using things like diastolic and systolic blood pressure. It's using your heart rate. So as an example, the diastolic blood pressure reflects afterload. The systolic blood pressure reflects the contractility of the heart. So we can utilize our standard vital signs. We can utilize the hemodynamics. We can utilize echocardiography in order to make these decisions. Now, as we, as a field, transition away from things like dopamine and transition more towards epinephrine or norepinephrine, what I remind people is that it's not about the drug, it's about what are you trying to do. So the example I give are twofold. If you have a term baby who has evidence of acute pulmonary hypertension, let's say from meconium aspiration, and is having the classic desaturation, pre-post ductal sat splitting, and you want to choose a medication to start in the setting of hypotension, well, you want to ask yourself, what are your goals? In that setting, your goals would be to raise your SVR, to raise your afterload. You need a drug to do that. You want a drug potentially to lower your pulmonary pressures, and you always want to be conscientious of your cardiac function. So in that sense, is there a drug that can easily achieve all three of that? The answer is no. But with an echocardiogram, if the echocardiogram shows normal cardiac function, then you don't have to worry about using epinephrine or dopamine. You don't need to use a medication to enhance contractility. You need a medication to enhance the afterload and decrease the pulmonary vascular resistance. A medication like vasopressin could be a good drug. A medication like norepinephrine could be a good drug. However, if you have severe left ventricular dysfunction or right ventricular dysfunction, then you're not going to necessarily want to use norepi or vaso as your first line medication because you need a medication to augment contractility. The point I'm making is that as you approach each hemodynamic perturbation, each hemodynamic injury, you need to think about what your goals are and tailor each cardiotropic medication to fit those goals. In terms of the preterm infant, you may have a preterm infant who has pulmonary hypertension. You may think about starting nitric. You may be in a resource-limited place and start sildenafil. The bottom line is the preterm myocardium will respond differently than the term myocardium. You may use nitric in a term baby for 3, 4, or 5 days. In a preterm baby with pulmonary hypertension, you may use it for 12 hours. So that's what we need to understand when I'm talking about the neonatal and preterm myocardial mechanics.
Thank you. I think it's always great as a review to talk about those things, and also for some of our fellows and residents to really understand how the difference plays a role in what we choose, but also what our active hemodynamic status is as we try to go through these. We don't have access to the ability to see by picture what's going on in the moment. I think it's also nice to touch on that you touched on the use of mother's own milk in cardiovascular health, because they're from the groups that are very interested in neonatal nutrition. There's a lot of focus on how do we prevent obesity in our preterm infants as they get older. But I think linking it with the other aspects of cardiovascular health and function is always interesting. Have you guys looked at how that may be different for different known disease states, whether it's infants with congenital heart disease, whether it's related to a syndrome or not? And you brought up the difference of things that we've found with trisomy 21 patients. Is there a differential effect of maternal milk for those populations as well?
Yeah, that's a wonderful question. I think others have studied the impact of mother's own milk with congenital heart disease, and the same principles that apply with the preterm population apply in that population. I think as we go forward, this is a hot area where I think it's a generally accepted practice that providing maternal mother's milk compared to formula is better for the gut, is better for the brain. And now, for the first time, we've shown it's better for the heart over the first year of age. I think as we go forward, it will be important for those who are interested in these nutritional registries to really hone in on different cardiovascular disease states to understand the different phenotypes. That's what it's really been about for our group, is understanding the different phenotypes and the different disease states. We have focused on bigger strokes like infants of a diabetic mother, HIE, PDA, twin-to-twin transfusion. We basically taken every disease that we can think of that relates to cardiovascular disorders and tried to phenotype them out from the gut to nutrition to the brain. And you can flip it around. If you're interested in the brain, you could do the same thing and look at it from the kidneys and from the cardiovascular system. So the short answer is the data is evolving. The hypothesis is that yes, maternal breast milk is best. Is it the cure for everything? No, but I have yet to see a study where it has a negative impact other than in babies with chylothorax. So with that said, I think breast is best.
We have a question from the group asking, how should we counsel parents on exercise tolerance or perhaps exercises in child's early development?
That is a wonderful question. A great paper was written by Karagos and Adam Lewandowski in Hypertension that really focused on the management of former preterm infants when they become children and adults. It's really no different right now than what you would normally do with enhanced exercise, good nutrition, good dental hygiene. But what they highlighted in their paper, and I'm happy to share it with the group, is that there should be kind of an extra visit for these ex-preterm infants when they get into early adulthood. Because as we know, anybody who has a child, you have pretty frequent visits with your children over the first 18 years of their life, at least yearly. A lot of it is for school documentation, so they will be seen by a healthcare provider. But once they age out of that environment, they can go years without seeing a healthcare provider. And what we're learning is that a lot of the people who have heart failure, pulmonary hypertension, ischemic disease are born preterm. And what Adam Lewandowski and Karagos have advocated for is special kind of extra visits with additional testing that can help unmask some of these preterm related long-term cardiovascular impacts.
Alison, can I have a question, or we have no time?
There is enough time.
Thank you very much. This was a very informational and educational lecture. I have a question regarding PDA ligation. When you were describing that, when you say like allowing the PDA to be significant and affecting the breathing afterload, like it's kind of a no-no, and we have to try to close it. And kind of puzzled by, in your experience, do you see an impact in kind of reduction of coronary lung disease or reduction in occurrence of chronic pulmonary hypertension or anything related to neurodevelopmental outcomes that can actually give a value to closing the duct versus to not to close the duct, other than the immediate effects on the cardiac function? And I'm not worried here about the post-closure syndrome because it happens anyway and it will recover. I'm looking for further on the line. Okay, those who had duct closure when they were significant, do we actually see better better prevalence of incidence of non-occurrence of chronic hypertension, chronic pulmonary hypertension versus others. Do you have any experience with this, and can you help us with that? Because we struggle with, should we close, should we not? And it's, as you mentioned, an eternal question we have no answer to.
It's a wonderful question. The way I approach the hemodynamic duct is there are three criteria that I look at. The first two criteria are related to in the moment, and the third criteria is related to the long-term effects. So in the moment, you're talking about pulmonary overcirculation and systemic hypoperfusion. You're talking about the impact on the lungs and long-term requirement for respiratory support and balancing that on sometimes babies are kept MPO, they're at risk for IVH, neck, pulmonary hemorrhage. If those could be mitigated, the next thing you're worried down the line is the impact on cardiac function. As the heart pumps more blood into the lungs and less to the body, it's almost doing double work. And is there a long-term impact on the cardiac function that we already know from what I just told you is already at a deficit? And the final piece of the puzzle is what is kind of the long-term approach? Like, how do you weigh gestational age and all of the comorbidities? So there is data that says the longer a hemodynamically significant PDA stays open, and that's all up to debate how you define that, the more at risk you will have on both the pulmonary circulation and the systemic circulation, the more at risk you could have in changing the milieu of the cardiac function. One other entity which I didn't talk about is babies who go on to develop pulmonary vein stenosis. There is a link or an association with longer exposure to left to right shunts, both at the atrial level, the ventricular level, and at the PDA level. Again, all of these are small case reports and case series, but I think the consensus is when you have a duct that's hemodynamically significant based on the criteria of the shunt balance, the criteria of the heart function, and the criteria of the potential impact on long-term comorbidities, that most people would favor closing the duct, but having to balance it within, the complications that can arise from either a ligation or a device closure. I have seen babies where ducts stay open for a long time, and it really does limit their ability to advance on their respiratory support. And as we all know, once you get to 34 to 38 weeks, if you miss that window to start taking a bottle, recent data has come out that if the oral development is behind at 34 to 38 weeks, then that will have long-term neurodevelopment out to 2 years of age. So I think those are the pieces of the puzzle that you have to balance. If you have a duct that's open and it's hemodynamically significant, but the baby's maybe on CPAP and weaning or in room air and tolerating feeds, and the nutritional support isn't impacted and the development isn't impacted, then I'm not sure I would rush to close the duct, even though on the echocardiogram it looks hemodynamically significant. The take-home point is you have to weigh the impact of the duct with the impact of all of the other comorbidities.
Thank you.
Thank you. It looks like, so we'll take the last two questions that just came in the chat box to round things out. One question, I think they're looking at what effects do micronutrients such as folate play on the neonatal myocardium, and are there additional nutritional needs we need to be thinking of in order to optimize the preterm and neonatal myocardium?
Yeah, that's a wonderful question. I think what we're hypothesizing is that it's the impact of HMOs and stem cells and also micronutrients. I wouldn't advocate for altering the way that we approach these babies with optimizing the calories, both the carbohydrates, the lipids, and the amino acids. I do think we're beyond the stage of being able to randomize these babies to less or more micronutrients to be able to determine the overall impact. We may be able in the future to look at specific breast milk analyzers. So as many people know, breast milk, we think it's 19 or 20 calories, and we fortify it up to 22, 24, 26, 28. I think there are some novel studies, some coming out of the Brigham by Mandy Belfort, really doing individualized caloric counting of each breast milk sample, so that will allow us to really titrate the micronutrients in order to get us to that goal calories, the goal lipids, the goal amino acids, the goal carbohydrates. So I think that's where the field is going. The take-home message from all of this, and this is to use the words of Patrick McNamara, it's a targeted approach for each individual. It's not only targeted with neonatal echocardiography, it's targeted with micronutrients, it's targeted with nutrition, it's targeted with the way we manage neurological outcomes, it's targeted with big data, stuff for the work that Danielle Rios is doing. All of this is targeted and individual to give us the most complete, complex picture of every single baby in our unit.
Thank you. And the last question that we have now, since we're a little bit over, is we know that mothers who breastfeed have less cardiovascular disease, such as hypertension and coronary artery disease. Is there any postulated link between the mothers and babies that is similar to the metabolic shift of pregnancy that is better when returned to normal when mothers lactate?
Yeah, that's a wonderful question. We wrote a little bit about that in our 2020 pediatric research paper, where we talked about disease prevention in the next century, and that was actually one of our working hypotheses too. That there's probably some link between those moms who breastfeed, who 20 years later have reduced cardiovascular disease, and the breast milk that these babies receive, where 10, 15, 20 years later, they also have reduced cardiovascular disease. Adam Lewandowski did one of the first studies where he tracked infants from the 1980s who received breast milk versus infants who received formula. And he showed that those infants, 25 years later, when they were adults, they had enhanced right and left ventricular function, the right more than the left side. And one of his working hypotheses is that it could have some similar mechanistic link to the link that you just described with the moms who breastfeed, who also have kind of enhanced cardiovascular function performance down the road. Great question.
Thank you so much. We hope that everyone has enjoyed Dr. Levy's wonderful presentation and answers to all the questions that we've asked him. And with that, we will end today and hope that everyone stays safe, and we will see everyone next week as well. Thank you, Dr. Levy.
Thank you. Have a great day, everybody.